All right. First, thanks, Kelly and Dirk, for including our paper in the program. So it's my great pleasure to share this paper, Driving a Bargain. This is a joint work with Christine and Dennis, my great co-authors. Both of them are in the audience. So one defining features in corporate contracting is significant price dispersion. So it's not uncommon for firms to pay different prices for the exact same services or good. So here, actually, we provide one example from our sample. Is we are plotting the prices for one insurer, specific insurer in Texas, to see their contracting prices with hospitals in Texas back in the years of 2019. So we plot like five different medical procedures. You can see X-ray exams on shoulders or hands. As you can see from the figure, typically the top paid hospitals by that specific insurers, actually their prices, contracting prices, can be 3 times as high as the lowest paid hospitals. So such kind of wide variation in the prices has significant implications in the market. So for one, you can imagine this is going to complicate the production decisions of firms. And also, these are going to make the consumer search less efficient and more challenging. So in light of this, the prior empirical and theoretical literatures has thought to understand the pattern about the price dispersion through the framework of bilateral bargaining. So many papers have discussed, for example, the differences in market structures, the firm conditions, the ownership or informations, how they're going to explain such kind of price dispersion. But at the end of the day, most of the papers are going to attribute the unexplained variation in prices to the concept of or differences in bargaining power parameters, which sometimes can account for a large portion. And they interpret this as the difference in bargaining power parameters as a difference in the skills of negotiation or their abilities in negotiation. So, however, many people complain about the concept of bargaining power parameters in the sense that they are saying this is a black box. We don't know what it really proxy for, either skills or something else. So this paper specifically, we aim to fill the gap and unpack the black box nature of bargaining powers. Specifically, we address the following 3 questions. So how managers' personal negotiation skills going to affect pricing, and how their negotiation skills, personal negotiation skills, are going to tie to the firm's bargaining power concept we typically talk in the theoretical literatures. And lastly, to what extent the managers, their negotiation skills are going to contribute to the price dispersion we observe in the data. Okay, so to address these questions, this paper focuses on the healthcare price bargaining in a business-to-business setting. Specifically, there are 3 key innovations of the paper. So first, we developed an out-of-sample measure of managers' personal skills and study its organizational impact. So these skills or this measure is derived based on the price paid in significant personal transactions buying a car. Okay, so the measure is also derived from about 50 million vehicle sales records in Texas. So combined with this measure, the second contribution here is trying to use the new large-scale insurance claim data. Through the lens of the claim data, actually we can derive detailed transaction or contracting prices between the insurance, in our example, with a different type of providers. So lastly, and most importantly, as alluded to before, so the key innovation here is trying to open the black box nature of bargaining powers and trying to propose one possible origins. So here we try to link it to the roles of individuals in negotiation and highlight the impact of their skill heterogeneities on the price dispersion. Just to provide more context, so this paper, the setting we focus on is hospital sector for privately insured patients. So you may ask why hospitals? So hospitals are the largest healthcare spending categories in the US. So in 2023 alone, the total hospital spendings reached around $1.5 trillion. So that's amazingly high. And then why privately insured patients, they covers majority of the population in the US. And most importantly, in this setting, the healthcare prices, they are negotiated bilaterally between the insurers and providers. So what do I mean? Here, I provide one example of local market structures used in Boston. So you can see the hospitals like Beth Israel or Mass General, they are very famous hospital locally, and they're going to provide medical services. And then the insurers like BCBS or Aetna, they're going to cover most of the cost. And importantly, the BCBS and the Aetna, these insurers, they're going to bilaterally negotiate with a subset of the hospitals in the local market to pin down the prices from P1 to P5 in this example. And our research, we try to see the impact of these managers running the hospitals, like Kevin or Marcella, they are the managers of Beth Israel or Mass General, to see their personal skills, how they're going to affect the negotiated prices from P1 to P5. That's the focus of our research. So after introducing the setting, let me summarize the key findings of the paper. So we find first, the manager's skills matter. So the managers with better negotiation skills, typically they can significantly increase their negotiated reimbursement rate for their hospitals. So the magnitude is large. One standard deviation increase in their personal negotiation skills we document is associated with 8.4% increase in the negotiated prices for the hospitals. And we find documented very similar impacts or magnitude even by looking at very specific medical procedures like X-rays prices. And we actually in the paper, we try to validate the measures through several exercises. For example, one exercise we did is to borrow Callie's Jeff paper to look at, okay, how managers' personal negotiation skills is correlated with their returns from real estate transactions. We find they are positively correlated, for example. So in the second part of the paper, we try to provide more evidence to support causal interpretations. So one thing we did is we look at the managers, they leave the hospitals due to natural causes like death, medical leaves, or retirements. We find that suppose the incoming managers, they have better negotiation skills. This is associated with a jump in the negotiated prices for that hospitals. And we also look at the counterparty on the table, on the negotiation tables, like insurance. We find typically for the insurance, if the market become more concentrated, for example, due to M&As between the insurers, these are going to generate or exert the negative price impacts on hospitals' prices. However, such kind of negative impact is almost muted or negligible among the hospitals, suppose they have a very high negotiation skilled hospital, the managers. In the last part of the paper, we resort to the structural approach, trying to link our negotiation skills measures to the bargaining power parameters typically people discuss in the theoretical framework. We find indeed they are positively correlated. One standard deviation increase in negotiation skills, personal negotiation skills measures is correlated with an increase of 0.06 unit increase in bargaining power parameters, which is bounded between 0 and 1, okay? And then suppose in the counterfactual, we eliminate all the heterogeneity or the differences in the individual negotiation skills, these are going to wipe out around 28% in the price dispersion we observe in the data that can be explained by the differences in bargaining power parameters, okay? So for the interest of time, I will skip the literature review part. Let me directly jump to the data. So the key data we use come from the DRG real-world data. We combine it with the American Hospital Association's annual surveys and HCRIS. So our final sample includes over 20 million outpatient visits to hospitals in Texas. In the data, we can observe very granular information regarding the patient ID, the insurer's ID and the insurer's names, like patient's age, gender, zip code, plan type, what time they visit the hospitals, and patient's diagnosis. Importantly, we observe the medical procedures provided to the patients. So based on that, we construct this follow the guideline of CMS. We construct this APC weight. You can imagine this is the measure to capture how much medical resources are used to treat the patients. For example, the X-ray on shoulder, they will be assigned with 2 units, while the X-rays on hand, they will be assigned with 1.5 units, okay? So another important variable we can observe is total paid amount during the patient's visit. So we call it allowed amount. And we use this allowed amount basically to back out the negotiated prices, unit negotiated prices between hospitals and insurers by dividing this APC weight. So in the end, this price index we get is a price paid by one specific insurers to another hospitals for 1 unit of medical services they provided. The average in the sample is $315 in the dollar term of 2022, okay? This is comparable to other studies. So the second big chunk of the data we use come from LexisNexis public records and also data Axle. So we manually match with hospital managers' information. We get very detailed information regarding their names, age, gender, race, last 5 digits, SSN number, addresses, employments, close relatives, and so on. On top of that, we observe like the social and professional informations, including their licenses, criminal filings, voter registration, mortgage, and so on. Okay, very granular. Thanks to Dennis. Okay, so the last part of the data we use come from Texas DMV. Okay, so we know this covers over 50 million new and used car transaction records in Texas. So we know the buyer's names, their home address, the dealer's names, their license number and locations. And on top of that, because we can observe the VIN number, which is like equivalent ID for the cars, we also know the actual sale price, not the sticker price. And also the transaction date, the make, model, trim. You can imagine like Honda CRV XL, that's a car my wife is driving. Like the year and the country of manufacturing, and also the mileage readings and so on. So we complement with some other data source in the paper. So with the data, the very first task is to construct the negotiation skill measures. So how we're going to do this? We project on the left-hand side is a log of the sale price for the vehicles on a bunch of fixed effect and characteristics of vehicles, dealers, and buyer themselves. Specifically, we include the vehicle make by model, by trim, by model years fixed effect. So essentially, we are comparing the sales of the same cars, the Honda CRV XL made in 2023, okay? And we also control the dealer fixed effect. So it's the same dealer selling the cars to 2 different buyers. We also control the year, months, and also the county fixed effect. We include the vehicle characteristics and also include the demographics of the buyers. So the demographic information we included because we feel like these are going to potentially affect the willingness to pay of the buyers. If you have the bigger households, you have more number of children, probably you're willing to pay higher prices for a larger car. But our results are robust by dropping these characteristics. And also we include the market conditions, travel distance, and so on. At the end of the day, we construct these measures based on these residual terms, var epsilon, okay? So we define negotiation skills as a negative of this var epsilon. So for example, suppose negotiation skills or the residuals is minus 0.1 or our measure is 0.1, which means these individuals buying the same car from the same dealers in the same months, they can negotiate 10% lower prices compared to another buyers. Okay, so this indicates to some extent they have better negotiation skills personally. So with that, the first validation exercise we did, stealing Kelly's paper's ideas, trying to see, okay, whether they are correlated with some other orthogonal settings. So one orthogonal setting is real estate transactions, okay? They buy the house, maybe later on they move, they sell the house. So we find our negotiation skills is positively correlated with the annual real estate transaction returns. So this is a kind of a comforting thing for us to see the measures somehow make sense. We have some other validation exercise for the interest of time. I will skip it here. They're in the paper. So with the measure on hand, the very first thing we test is to see the correlation between the individual skills measure and the hospital negotiated prices. So we run the following specifications. On the left-hand side is a log of hospital price index. On the right-hand side, the key measure, the key variables is the negotiation skills we constructed. We include the insurer fixed effect, hospital fixed effect, year fixed effect, and then here is our results. So basically, just one more word, we actually look at both the hospital system, which is more like the headquarters, you can imagine, of the firms, their CEOs, their skills. And also we look at as robustness, we look at the kind of facility, which is like the subsidiaries, the local managers or CEOs. So both results are somehow consistent and point to a positive correlation between the negotiation skills and the hospital's reimbursement rate or negotiated prices, okay, with the insurers. And the magnitude is large. So take the second column, actually our preferred specifications here. So one managers, they can negotiate 10% lower in their personal vehicle transactions. This is going to translate into an average of 5.45% increase in the negotiated prices of their hospitals with a specific insurers. Okay, so we also conduct some robustness check by looking at, rather than the patient or the hospital's kind of price index, we directly look at the medical procedures like offered by hospitals. So we look at, particularly we look at the X-ray exams prices because they are widely regarded as homogeneous quality across hospitals. There's no other type of concerns involved in the, like regarding maybe the quality differences. So there we still observe very consistent results. Magnitude is still like comparable to the previous results you see, okay? So you may still ask, okay, this is all this correlation. So next we will try to tackle a little bit of the endogeneity concerns and provide several evidence to elevate the endogenous matching between the hospital managers and the hospital themselves, okay? So the very first thing we did is just follow the literatures and then to see the turnovers unrelated to performance, like they are due to the death, medical leaves, and retirements. So we still observe a very significant positive impacts of this group of natural turnover hospital managers, their skills, and the hospital prices. So the second exercise we did, we are trying to hold basically the matching as fixed, the managers and hospitals. We are looking at the counterparties, the insurers, okay? Because that's a counterparty you have to negotiate. So the idea here is that suppose the insurance market concentration become different, say they become more concentrated, which means like when you are negotiated with a stronger position insurers, you're facing more headwinds, okay? Then you have to very likely you have to negotiate the lower prices. Indeed, that's what we find. Generally, you see a negative sign. Suppose the insurance market become more concentrated. However, the negative impacts are almost muted if you look at the hospitals run by high negotiation skills managers. The negative effects will be more pronounced, way more pronounced among the low negotiation skills hospitals. So with that, in the last maybe 7 or 8 minutes, I will try to talk the last part of the paper to link our individual negotiation skills measures to the bargaining power parameters of the firms, of the hospitals. So the way we do it is to follow the structural work in the literatures like Garrison Karen et al. 2015's paper and Kate Ho and Robin Lee, their econometric papers. So suppose in the market, we have 3 types of players: insurers, hospitals, and patients or enrollees. And then we assume they are trying to negotiate prices, benchmark prices between hospitals H and insurer I. So the way they price all the medical procedures, you can imagine, is to multiply the benchmark negotiated prices with the APC weight. This to measure how much medical resources actually used to treat the patients. And the way we do it is to do it separately for demand side and supply side. So for the demand side, we have granular patient level data. We see, okay, which hospitals actually they prefer to visit. We use a very standard Login models to compute the expected choice probabilities and willingness to pay. And then also for the supply side, this is kind of the key part. Typically, the literatures, they would say the hospitals and insurers, they would negotiate bilaterally, trying to split the total surplus. So here, the key measure here is the beta H, measures the bargaining power of hospital H, okay? So as I mentioned or alluded to in the introduction, most of the papers, they argue, oh, for these unexplained price dispersions, they are actually captured by this parameter, the differences in the parameter beta H. So that's how they interpret this. So our task is trying to say, okay, this beta H actually can be largely captured by individual negotiation skills. So the way we do it is we try to break down the total surplus based on the demand estimation, and then how we estimate the beta edge very intuitively is relative to total surplus, these two negotiation parties, they try to negotiate, how much surplus actually will be grabbed by the hospitals. So that ratios measures the bargaining power parameters. Okay, so I'm gonna skip a lot of technical part regarding the estimation, but in the end, basically we can estimate or back out the bargaining power parameters. In the literature, typically people say, okay, that proxy the negotiation skills for that hospitals or for the firms, following these equations. And with that, we conduct actually several counterfactuals. The very first one is trying to say, okay, what underlying determinants or factors are going to affect the bargaining powers of the hospital or of the firms. So we run a horse race regressions with the beta edge we back out on a bunch of hospital characteristics, including the negotiation skills of the managers. So you will see actually compared to all the other significant factors, like whether they belong to one system, which means they have larger presence in the local market, or whether the market shares. Typically, the market shares imply maybe better negotiation positions or larger bargaining powers. That's indeed the case. But compared to these obvious observed factors, what we uncover in this exercise is that the negotiation skills of the managers, actually, they are one of the most important variables affecting the bargaining power parameters. So they are highly correlated. And then the next thing we did is to see, okay, how such kind of heterogeneity in the negotiation skills measures for the managers, how they're going to explain the price dispersion we observe in the market. The way we do it is just to look at each market and take the variance of the markup across different hospitals and insurer pairs. And so in the counterfactual, what we do is we first say, suppose all the hospitals, they have equal bargaining power parameters. That's a benchmark. Compared to the equilibrium price dispersion we observe, that's basically the contribution coming from the firm's bargaining power parameters differences. And then in another counterfactuals, what we do is using the projection we have in the first exercise. So we just assume all the managers, they have equal negotiation skills. So these are going to affect the bargaining power parameters. And then you will see these are going to translate another decline in the price dispersion. So we compare these two gaps. You will see in the end, the differences among the managers' negotiation skills, they're going to explain around 28% the change in the price dispersions that due to the differences in firms' bargaining power parameters. Okay, that's a large number and highlight that negotiation skills of these individuals can be a kind of one key determinants of the firm's bargaining power. I think, yeah, that's pretty much all I have. So to conclude, this paper developed a measure of managers' negotiation skills inferred from their personal transactions. And then we try to link this to their firm's negotiation outcomes. So this may have the implications for the hospital insurer negotiated prices. And also we find that this can also unpack the black box nature of bargaining power differences we observe actually in the model or in the data. Okay, I'm looking forward to Manuel's discussion.